Good morning, ladies and gentlemen. In about 8 minutes, I will try to prove that our non-dominant upper extremity is less resistant to acute fall-induced injury. It is a statistic of a half decade observing school-age children in playground fractures, especially of the pediatric distal humerus. Let's go to introduce you to the three most common fractures seen in the school-age children in the area around the elbow. First of all, the supracondylar humerus fracture is the common type of elbow injury leading to the operating theater, especially the type 4, Gartland type 4. It is a seldom open fracture. Males are affected more likely than females. 6 to 10 years of age is the most common age range, and they are seen on the left side more frequently than on the right side. Nervus vascular status is about in 50 to 20% of the school-age children impacted, and that's why we have to get through a very complete clinical investigation. It is a type of fracture that can lead to anatomical and functional consequences like as varus or valgus deformity in a second time. The second most common type of elbow fractures in school-age children is the lateral epicondyle fracture. And if it is dislocated more than 2 millimeters, it has to be operatively fixed up. Males are affected more likely than females. Age to 12 years of age is the most common age range, and this kind of fractures are seen more likely on the left elbow than on the right one. It can lead to a malunion, non-union, and pseudarthrosis, and of course it leads occasionally to bone deformity of the elbow in second time. Medial and radial nerves should be checked before and after open reduction and stabilization. Most common type of open surgery in school-age children is this kind of fracture. And the third most common type of fracture is the medial epicondyle fracture that has to be operatively fixed up if it is dislocated more than 5 millimeters. It is most common in teenagers. Males are affected more likely than females. Right one is more likely than the left one. It is a common cause of blocked elbow. It appears often with posterior dislocation of the elbow. Ulnar nerve should be evaluated and estimated pre-open post-op, and open surgery and internal stabilization is needed to fix it up. It can lead to elbow deformity as well. Trying to answer my question, I would like to say that the most common 3 reasons that can prove this hypothesis that the playground fractures are more likely to be seen on the left side in a right-handed population of school-age children is first of all the hammer glass effect between olecranon and distal humerus. Olecranon is a big moving bone mass into its full-ended distal humerus and behaves like a hammer. The distal humerus, the other side, is a bigger one but not moving bone mass and has too many ossification centers and gel-like fibers. It behaves like a glass. The lower walls can allow us to tell that osteopenia is more likely to be seen on the left hand comparing to the right hand. And of course, the sarcopenia is most likely to be seen on the left hand because the right-handed population of school-age children uses more likely the right one and less likely the left one, such as muscular hypertrophy, sarcopenia like elbow muscles due to muscular hypertrophy, muscular weakness, physical inactivity, and of course the low testosterone in school-age children and high myostatin in blood leads everything, what I say, to playground fractures most likely to be seen on the left hand than in the right hand. We have examined about 213 right-handed children that were admitted and operated in our hospital. And all this kind of children had the common mechanism of injury falling backwards onto the outstretched hand with hyperextensions at the elbow. Traumatic injuries from direct blow of the elbow were ruled out. And the results were fascinating. The most likely elbow fractures are seen on the left elbow and less likely on the right elbow. In the kind of supracondylar fractures, you can see that in about 165 children, 105 elbow fractures were seen on the left side. The same in lateral condyle fractures. In about 29 children, 21 of the elbow fractures were seen on the left side and just 8 on the right side. Just in the case of medial condyle fractures, in about 90 children, 6 were only on the left side and 13 on the right side. But in summary, you can see that in about 213 children, the 132 elbow fractures were seen on the left hand in all that right-handed population of school-age children. Discussion. It remains to prove this hypothesis with studies on anatomical and biomechanical elbow models with the use of emerging techniques such as MRI, BMD, histopathological assessments, elbow movement analysis. But you have to remember that in the battle between the moving growing elbow and the static growing distal humerus, the winner is always the elbow. Conclusion. Clinical observation is always important and the stimulus for new scientific ideas. There is a strong statistical tendency that the recessive elbow is less resistant in fall injuries comparing to the dominant one. More emerging studies on this issue should be done. And very, very important, in my opinion, schools' curriculum with appropriate sports exercises and regular physical activity can strengthen the recessive elbow and decrease the percentage of elbow injuries and the appearance of delayed varus or valgus deformities. Stronger elbow decreases the hospital admissions of school-age children and minimizes the need of surgical fixation. Have a nice day and discover greens. Thank you for your attention.